Hello and welcome to another continuation of your Chapter 8 video lecture, where we are going to discuss HIV and AIDS. So the first thing we need to discuss is what is the difference between HIV and AIDS? HIV is in reference to the actual virus. So H stands for human. This is, again, our retrovirus, meaning that it's not able to reproduce outside of the human body in order to cause infection. HIV has to reproduce and survive in a human host. I is standing for immunodeficiency, and this is referring to an unhealthy immune system. Our immune system is the body's natural defense against our infections and diseases. And V stands for virus. It's the disease or condition that is caused by a virus. For example, we have the common cold and the flu that are all caused by different viruses. The flu, is the influenza virus. And so what our HIV does, the virus, is going to deplete our body's T cells, specifically the helper T cells, and it creates this generalized immune deficiency. It's attacking and hijacking our immune system so that it allows us to be susceptible to other infections. So as time goes on, it is going to invade our CD4 or Th cells. And if you remember from our review of the adaptive immune system, our helper T cells are necessary for an appropriate immune responsiveness. They are the cells that mediate between our antigen presenting cells and our other immune cells. So what about AIDS? This is going to be the most advanced stage of infection caused by HIV. So we're going to talk about the stages in a couple slides, but just so we know, A is going to stand for acquired, because HIV doesn't run in families like we see in diabetes or heart disease. It has to enter the body through some external method. Then we've got I. This is for immuno, referring to our immune system. And then we've got D for deficiency. And of course, this means that we have a defect within our immune system. It's not functioning properly. And syndrome is a term given to some type of disease or disorder that has a group of signs and symptoms that occur at the same time that characterize the condition. So let's talk a little bit about the epidemiology of HIV. This is a blood-borne pathogen, and it can take place most commonly through heterosexual activity. It is worldwide, and we do see that women are affected with HIV or AIDS more often. It was first identified in the early 1980s, and it's estimated that 38 million people are living with HIV globally, and this stat was taken from 2019 statistics. And currently we are seeing that sub-Saharan Africa has the highest number of people living with HIV at about 66%. Now let's review some information that we probably covered in biology and microbiology, but here's the structure of our HIV. We know again that it is a retrovirus, and so what that really means too is that we've got viral RNA here, and so this has to be converted to DNA before the viral genes can be expressed to make copies of their RNA virus. And it is made up of two strands or chains. And we can see that it's protected by this double layer, this round lipid bilayer that creates a viral envelope around the genetic information. And we have at least 9 genes that are going to encode at least 15 viral proteins. So we'll talk about the mechanism on the coming slide of how this takes place. But we know that along with the genetic information, when the virus comes in, we have to have reverse transcriptase. Again, that is going to help to convert RNA into DNA. And then we have integrase that helps to integrate it into the DNA, and proteases that help cut proteins. Some of the important displays that we see on the envelope are GP120 and GP41. These are important markers that help identify this virus as HIV. So let's talk about that life cycle. We are going to see that HIV is first going to attach. Do you remember attachment or adhesion? That takes place first, where we have receptors on our human cells. And by attaching, then we are going to have that contact with the receptors here. Remember, we've got the GP120 that allows us to do that, and the capsid is going to be released into our cell here. Note how the viral RNA is moving through the cytoplasm, and then that is going to utilize its own enzyme that it brought with it, the reverse transcriptase, to change RNA into DNA. Then that DNA can move into the nucleus, and we use integrase to place it into our human DNA. Now our natural process is going to take place, right? Ribosomes are going to come and eventually read the mRNA that we've created through our processes of transcription and translation. And so now, as it's reading that genetic information, it's going to start to create viral proteins without even knowing it. So it really is hijacking the machinery of our cell in order to create those viral parts. It puts that all together, and then it is ready for budding, and it exits the human cell through exocytosis and is on its way to go and infect another human cell. So by going through this process, we have some sort of host cell membrane, because remember, when we exocytose, we take a part of our cell membrane with it. And so now it makes it less vulnerable to our adaptive immune system attacking it, because it recognizes it as our own self. Now let's move into talking about CD4 count and viral load. So when we think someone is infected with HIV, we always want to do a CD4 count. This is representing the number of white blood cells, specifically the helper T cells, to see how much exists within our body. Have they been destroyed? Do we have a lower amount? And so the higher your CD4 count is, the better you are able to fight HIV and other infections. So normal CD4 count is going to be from 500 to 1,500 cells per cubic millimeter of blood for adults or adolescents. And if we have a very low CD4 count, meaning we have less than 200 cells per cubic millimeter of blood, that's one of the ways we can determine if someone that has HIV has progressed into AIDS. Now, you may have heard us, especially during the pandemic, talking about viral load. And so this is going to be the amount of HIV we have within our blood. And we measure this based on the amount of RNA of that virus that we have within our blood. And it's thought that this measurement is actually more accurate than doing a CD4 count. So of course, if someone is not infected with HIV, then they are not going to have a viral load at all. So what we really use the viral load for is to give us information on how well antiretroviral therapy, which is one of the main therapies of HIV, how well that therapy is working. And we call this ART, again, antiretroviral therapy, ART, so ART. And so how good is that therapy at controlling that virus? The goal is to move your viral load down. Ideally, you want it to be at undetectable levels, and it will be undetectable if it's under 40 to 75 copies in your blood sample. So at that point, the virus isn't completely gone from your body, but it's below what the lab tests can find. and one will have to stay on medication in order to make sure that their levels stay low and undetected. Having this undetectable level means that a person cannot transmit HIV to another person sexually. So this is another form of prevention, but of course, if they stop taking their medication, that viral load can creep up and they can transmit it to someone. Now, I mentioned we're going to talk about the stages of HIV, and here are the most common stages here. Stage 1 is known as acute HIV infection. This is going to take place within 2 to 4 weeks after infection, and we start to see that a person has flu-like symptoms, and that is basically showing that your body's trying to get rid of the virus. We'll not even realize that we're infected with HIV, but might think you have a cold or the flu or something like that. At stage 2, this is called clinical latency. And I also want to draw your attention to where the CD4 counts are going to be. So at stage 1, you still have above 500 cells. Whereas in stage 2, now we're starting to see those helper T cell numbers drop. So it's between 499 cells. And at this time, we see that the virus within our body cells are reproducing, going and infecting other cells. So it's almost dormant. It's kind of working in secret. And the duration of the stage does vary from person to person. At the end of the stage, the viral load will increase and the person's immune system is going to slowly decrease in efficiency, so we might become a little bit more susceptible to infections taking place. Stage 3 is where we obtain full-blown AIDS. This is when we have less than 200 cells. Our helper T cells are low, and so this is severe because now we have very minimal protection within our immune system to any infection. So even our microbiota might become an opportunistic infection and start attacking our body. So a person can survive this phase for an average of 3 years, but if they are going through art, it may last a lot longer. This is just a list of some of the clinical manifestations. We talked about how in that first stage, we are going to have more of those flu-like symptoms and create also formation of anti-HIV antibodies that we would find by doing certain blood tests. Next, our symptoms are going to show some early immune dysfunction. This can include lymphadenopathy, fevers, night sweats, a surge of viral production, and a drop within our CD4 cells like we saw on the slide before. And so as we drop that, we are going to start to see more opportunistic infections and tumor formations. And our last stage will bring about AIDS, which we said was more serious and can lead to opportunistic infections and cancers, and debilitating chronic diseases such as wasting syndrome. We can also have Candida albicans infections. We can have pneumonias, lung diseases, respiratory distress syndrome, neoplastic mucocutaneous disorders. We can have persistent vaginitis, cervical dysplasia, pelvic inflammatory disease, peripheral neuropathy, liver dysfunction or renal impairment. We can also have some rheumatoid arthritis manifestations as well. So we are going to do a discussion board this week on opportunistic infections, just so you can get to know them a bit better. These also are going to represent signs that our immune system is declining, and it could be life-threatening. So it is the most life-threatening, of course, when we are in stage 3 of AIDS, when we have less than 200 cells, helper T cells going on. So they can cause death for people living with HIV, not AIDS as well. One of the goals in treatment of HIV is to lower the risk of getting these opportunistic infections and keeping that viral load low. So for HIV treatment, when you are newly diagnosed, you want to start treatment right away. And the goal is to lower the level of the virus within our body so we can live a longer and healthier life. We can also think about the health of others by reducing the risk of transmitting HIV. Fun fact, the average lifespan of someone who is diagnosed with HIV at age 20, who is taking medication regularly, is 71 years old. So it's not necessarily a death sentence anymore. You just have to be really conscientious and, of course, have the financial ability to take that medication to continue through your lifespan. Unfortunately, if someone is diagnosed with HIV at age 20 and does not take medication, then their lifespan is going to significantly drop. They can live up to 32 years of life. So I've mentioned this before, but in order to diagnose AIDS, we need to do a blood test and see that we've got decreased helper T cells, less than 200 cells per cubic millimeter of blood. And we talked about ART as a treatment. And so it could be a combination of these many different types of drugs. I won't go into detail for these. That should be covered in a pharmacology course. And then with this treatment, we should see that death is reduced significantly, although there is no cure for HIV or AIDS. So how do we spread HIV? HIV, we know, is passed from person to person through the exchange of body fluids, and this could be done in 3 different main ways. First is going to be intercourse or sex. So anal sex is going to be the highest of sexual transmission of HIV. This is due to the lack of elasticity and thinner lining of the anus. So we've got a concentration of HIV higher in the rectal fluids than it is within semen. And both men and women can have anal sex. Having anal sex can prevent pregnancy. However, it does put a person at risk for HIV and also other STDs. Vaginal sex is the second highest of sexually transmission of HIV, and oral sex carries the least risk of sexual transmission of HIV. The second is going to be through blood contact. So doing things like sharing needles, and this is typically going to take place during drug use. And of course, now we always test blood before blood transfusion, but before our blood supply was tested for HIV, people would get HIV through blood products. Now that isn't an issue anymore. And then we also have opened wound to opened wound. For this to take place, it could be during a contact sport, such as soccer, football, baseball, and so forth. Any sport where an open wound can take place, and especially if it is a contact sport. For that reason, when someone is injured, we do want to take them off of the court or the field or whatever sport it is. And then third is going to be from mother to child. HIV can be spread from an HIV positive woman to her child during pregnancy. And this is the most common way that a newborn is going to get HIV. Now, it is possible for a pregnant woman to take medication while she's pregnant to prevent or try to reduce the risk of transmitting HIV to the fetus. And in some situations, the woman with HIV may have a scheduled C-section to prevent that transmission from taking place as well. Babies who are born to women living with HIV do receive HIV medicine for at least 6 weeks after birth, and the medication helps reduce the risk of infection from any HIV that may have entered the baby's body during childbirth. Also, this mother should not breastfeed because HIV can be transmitted in breast milk, so baby formula is recommended. Last thing we're going to talk about is pediatric AIDS. This is, again, when it's transmitted during pregnancy, at delivery, or through breastfeeding. Like we said, we can have them take medication. And what we see is that there is neurological involvement, and infection can progress rapidly if treatment is not started.